So maybe we're recording. Hello, good morning. So maybe I'll introduce myself, and then Leslie and Wendy, you can introduce yourselves at your times, rather than 3 introductions at once. Okay, so I'm Christy Sutherland. I'm a family doctor and a diplomat of the American Board of Addiction Medicine. I'm from the East Coast, and now I live on the West Coast. I'm the medical director of the PHS Community Services, so in the Downtown East Side, and I'm a clinical associate professor at UBC. I'm on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations, and I'm grateful for this, and I thank them. So for my conflict of interest, I've been working in the Downtown East Side for 12 years now. Oh, everyone's on mute? Okay. It's changed me. Absolutely, it's changed me to work in this community for these years, and I'm very grateful, and I love my work there. But it's changed my perspective on the world. So that definitely contributes to bias for me. I also take funding from CIHR for research. I don't take any pharma funding. So this has been terrible. And, these numbers were not a surprise to people who work in the field or who know and love people who use drugs. It's most people. So that 2021 was the deadliest year for overdoses in BC, which is just horrific to think that we're 5 years into a crisis and it's only getting worse. That more than 22,000 Canadians have died over this crisis, and that's an underestimate. And that it's a costly system that we're in right now, where drug enforcement costs Canadian taxpayers around 2.3 billion. So we're spending a lot of money on a system that is causing harm. We're arresting a lot of people for possession of drugs, and a lot of it is for personal possession, not for trafficking. And you couldn't pick a worse way to set up drugs in society, because drug supply, distribution, and profit is controlled by organized crime. So here's this heartbreaking graph that we see so often, where we can sort of acknowledge those 2,224 deaths that happened this past year. And then even on top of that, all of the non-fatal overdoses. So I think about, just even my clinical team, but all of the people who work across BC and Canada to reverse overdoses every day, and how many more deaths there would be if not for all that work. So we can see those numbers marching up. So I started practice in 2010, and I remember it was a different world than it is now in terms of how many of my patients have died, and that how I practice medicine. And that it's much more prevalent for death than when compared to suicide, motor vehicle collisions, homicide, and prescription drugs. Often people have a lot of stigma about people who use drugs and think that it's a Downtown East Side problem. So I always like to show this slide, and it's rates of death per 100,000. And you can see rural BC has a huge problem with overdose and death. Here's 2020. So the darker the color, the more death. And then here's 2021. So it's just tragic. Carfentanil, so we're seeing increased contamination in the drug supply. So in more deaths, carfentanil is one of the culprits. 71% of those dying were aged 30 to 59. So young people, many years of life lost, and 78% were male. And then we're seeing increased benzodiazepines contamination in our supply, which makes overdose management much more complex when someone is having a benzodiazepine overdose. And it also makes withdrawal more complex. And it also makes you sort of achieving stability more complex in the medication options that we have. So how did we get here? Like, why are we in this sort of nightmare of death of people we love? We're seeing increased potency and increased contamination of the drug supply that's led to this increased death. And that I've really enjoyed reading and learning about this topic about drug policy in Canada, because it really lets you zoom out and say, why did we set it up this way? I think a lot of people think that drugs were always illegal, or that drugs are illegal because of drugs are bad. Not this group, probably. But when you talk with, you go to a dinner party and you talk to people, they're like, oh, I think that people shouldn't use drugs, and so I'm glad they're illegal. But it doesn't work that way. It's really reductive. And that drugs being illegal is not the baseline of society. We can see the history of drugs becoming illegal for the past 150 years, and much of it is based on racism. So before colonialism, the psychoactive substances were used and were safe. And that Vancouver, actually, where I am, is the birthplace of prohibition in Canada. driven largely by anti-Chinese racism and perceived threat to white middle-class purity. And that's from Susan Boyd, who's an incredible Canadian scholar. So in 1907, there were massive race riots in Vancouver where thousands of white people went into Chinatown and destroyed it. They smashed businesses, they hurt people. It made international news, and it was sort of an embarrassment for Canada. The Prime Minister sent a delegation out to Vancouver to find out what had happened, and they met with mostly white people who blamed opium and the Chinese population on the riots. So that delegation went back to Ottawa, and they passed without any debate the first Opium Act of 1908. So that was the moment that drugs first became illegal in Canada. We can see over the coming decades how this legislation evolved and changed. And then with this evolving legislation, that drug use has become more dangerous. So we have many iterations of it, and then also international treaties that Canada has joined in order to also gain access to international trade. And that even just the names to the 2012 Safe Streets and Communities Act. So to sort of, make it seem like it's working, and that for each of these iterations of these documents, they add new illegal substances, precursors, which really just shows the futility of having drugs being illegal, because how can you keep up with chemistry? The National Anti-Drug Strategy in Canada in 2007 was millions of dollars. It supported mandatory minimum penalties, which has never been shown to be protective for a community or to decrease drug use or to decrease death. It abolished and tightened parole review criteria. It reduced credit for time served in pretrial and restricted use of conditional sentences so that there was less purview for the judicial system to make decisions based on individual context. And when we look at the funding, most of it was for law enforcement. And this is a wonderful book. I would encourage you to read it. As many socially constructed ideas about drugs have been codified into laws that govern how we may access and use these same drugs. So as a clinician, this really struck me because when I think about what causes harm, like that alcohol causes cancer or cigarettes cause cancer, heroin doesn't cause cancer. That heroin is actually much less harmful, the molecule itself, than alcohol. And so it doesn't make sense at all if we're looking at harm for what is legal and what is illegal. So in 1969, the government commissioned a committee to figure out what was going on. They analyzed drug policy in Canada, and they advised that criminal sanctions against people who use drugs be reduced, the offense of the possession of cannabis be repealed, and that opiate users should be offered medical treatment instead of criminal punishment. And no surprise that none of those recommendations were implemented. So 1969, so this has been a conversation going on for decades. It's complex because drug policy covers so many areas of society. It covers our justice system, so lawmaking, interpretation of law, judicial decisions, and use of force. But then we can think about housing and shelter and social policies where housing can require abstinence, or resource allocations for services, like how is money spent in our system? How are our cities planned in terms of shelter and public space and safe indoor space for people? How is our healthcare system set up? School planning, like are you urine drug testing the football team? Work safe and employment, like for safety sensitive positions, and drug testing, like that drug policy is really all encompassing, which can make it complex. It's not an easy solution. But really we can see that because of the way the system's set up, that if you use drugs, the outcome of your drug use is quite determined by your race, your gender, your wealth, your social capital, your health status, the purity and strength of the substance, if this is known, and the context of where you use. So in an alley versus a fancy restaurant. All drugs carry risk, and I think addiction medicine is quite guilty of overstating the risk of drug use for many years, and then that's really been a horrible breach of trust from the medical system to the people we care about when you say that that all drugs are bad. When people sort of question you quite reasonably, but all drugs do carry some risk, but those that are legal and illegal, but most of it does not have to do with the molecule itself. Most of it has to do with the context of the person's life. Ryan Marino is a great toxicologist and addiction and emergency physician on Twitter. And I really like this slide. And so I put it in all my talks now, that most people who use drugs never see the inside of a jail cell. But people whose drug use is criminalized are people who often are Indigenous or Black here in Canada. So many of us already live in a world of decriminalization because of our privilege. Alcohol prohibition did not go well, and 100% of people agree with that. They made millions of dollars, the amount of death, blindness. There's Al Capone. He was only 29. And then he went to jail for tax evasion. But that this was a terrible system. And it's legendary of what a terrible system it is. And thank goodness alcohol has had ongoing prohibition, because think of how many more people would be dead from the Tommy guns and the contaminated supply. But that it's very strange, I think, that alcohol prohibition ended and then we stopped there and we didn't continue to lift prohibition on other substances. This is a quote from Harper's. John Ehrlichman, you might recognize his name. He actually went to jail because of Watergate. He was a top advisor in Nixon, and he was one of the architects of the war on drugs in the early 80s. And Harper's was doing a history of the war on drugs, and they wanted to go and interview him, and he didn't really want to be interviewed. And so this is sort of him just like talking through the crack in the door. And he said, "You want to know what this is all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and the Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did." I thought this was a mic drop moment. When the person who created the war on drugs says, oh, it was all based on racism as a political strategy, surely that should then lead to us stopping the war on drugs. I was maybe young and naive. This came out a few years ago, but I was like, oh, great. Okay, so it's really quite clear that what we're doing is really wrong. But unfortunately, there was not the subsequent policy changes that I was hoping for. Sometimes in Canada, we like to think that we don't have racism, or that we're just super nice, but that Canada's drug law is very racist. But historians have demonstrated that drug law in Canada has not been a benign phenomenon aimed at safeguarding the health of Canadians, but a tool of social control directed unevenly at some groups of people. So that points to Indigenous people and alcohol, that under the Indian Act, Indigenous people living in Canada were prohibited from buying alcohol from 1884 to 1985. It was also illegal to provide an Indigenous person with alcohol in any setting, and Indigenous people were barred from entering any licensed establishment, and the result was jail time. So we had like a microcosm of alcohol prohibition for one population, and we harmed them. One of the specific, really heartbreaking harms that came out of this policy was for Indigenous veterans. So there were many Indigenous veterans. I have a photo here of one, but there's lots of resources online to read about the incredible heroism. And so these people was served at great personal expense. And while they were enlisted, they were allowed to have alcohol while serving in the war, so with their comrades. But upon return for war, Indigenous people were barred from legions. And so that was the main gathering place of veterans across Canada, and any non-Indigenous veteran could attend. So Indigenous veterans had much less access to information, benefits, and programs, and were cut off from the veteran community when they returned to Canada. And because of prohibition, Indigenous people were forced to consume alcohol quickly and to avoid arrest, and then had increased danger while drinking alcohol. So in that wonderful book, 21 Things You Might Not Know About the Indian Act, there's a quote that said, "The Indian Act prohibition set the stage for the pervasive stereotype that Indians suffer from an alcohol intolerance." So we can see in this very specific example of prohibition harming a very specific population. This is an old classic. In medicine, we love a U-shaped curve. That what we are in right now is the top left, the unregulated illegal profits, where organized crime is buying mansions here in Vancouver. What also we don't want is tobacco in the 60s with unregulated legal profits, where an industry or a massive corporation is, sponsoring jazz festivals and having Joe Camel attract children to start smoking at an earlier age, and that the profits are going to this corporation. What we want is the middle, the public health model. And how that looks is up for debate. That's why we're talking today. And that it can look different for each drug. A lot of times when I talk about how I want all drugs to be legal, people will envision the liquor store and they'll say like, oh gosh, Dr. Sutherland, do you want people going to the liquor store and also buying crystal meth? I'm like, well, maybe, but maybe not. Maybe it looks different for each substance depending on how we set things up. So our current system is massive amounts of profit for the illegal market, and that's from the UN Office on Drugs and Crime, and it's probably a great underestimate. The amount of murders, disappearances, the violence that happens because of the current system is horrific. And despite this, drugs are easier to obtain, more potent and cheaper than ever before. This is from Dan Werb. He's a wonderful Canadian researcher. And contrary to conventional wisdom that increasing drug law enforcement will reduce violence, the existing evidence strongly suggests that drug prohibition likely contributes to drug market violence and higher homicide rates. And this is because if someone steals from me or I enter into a business deal and someone doesn't meet the contract, I can take them to court. So I have recourse through the system to have justice and get my money back, or whatever it is that we're arguing about. But in the organized crime, you can't take someone to small claims court for non-delivery of an item, right? So that the violence is the recourse for solving those issues. So organized crime controls supply chains. So there's so much harm to the environment and to communities from supply chain, from the product to the price. And we see this every day. We see this violence, this potent, easier to transport products such as fentanyl, no quality control, contaminants to the supply that leads to overdose and death. It's an incredibly racist system. The USA has the highest rate of incarceration in the world, and nearly 80% of people in federal prison and almost 60% of people in state prison for drug offenses are Black or Latino. After prison, you're 50% less likely to have employment. And 1 in 13 Black people of voting age are denied the right to vote because of laws that disenfranchise people with felony convictions. In Canada, crime has been decreasing over the past decades, but the number of Black people in prison has increased by 90%, and our total prison population has also increased. Visible minority prisoners increased by 75%. I read an interesting paper where they did an FOI request for police records in 5 cities across Canada and demonstrated Canada has a systemic practice of police profiling and harsher sentencing of Black and Aboriginal peoples. I use Indigenous or an Aboriginal depending on the source that I got the information. In Vancouver, Indigenous people make up just 2.5% of the population, and yet accounted for 15.6% of those arrested for cannabis possession in 2015. I mean, I think that alone just should end the war on drugs. Like, how can you say a system is working when these are the kind of numbers? Indigenous people account for 26.4% of federal prison population, despite representing only 4.6% of people in Canada. Sorry, I shouldn't say Canadians, I should say people in Canada. I'll change that. And 34% of federally incarcerated women are Aboriginal and 21.5% of federally incarcerated men. So Susan Boyd, again, this wonderful scholar. In Canada and the US and the UK, the majority of women sentenced to prison for drug importation and exportation are foreign nationals, poor racialized women whose choices are framed by global and national political and economic concerns and Western demand for specific substances. It's quite costly to keep people in prison. Robin Maynard has this wonderful book, Policing Black Lives, that I would highly recommend. And she says that drug law enforcement has been an acute form of harm experienced by Black communities, including police stops, arrests, jail, prison sentences, immigration enforcement, and social service policy. The way that I entered into this conversation was through being a family doctor, and that I could see that when my patients were arrested, and even if they spent the night in jail or a weekend or then went to prison, I could see the harm that it did to my patient population. So going to prison increases your risk of HIV, it increases the risk of Hep C, and it interrupts primary care. Trying to stay out of jail means that people inject quickly in unsafe situations. They might not call 911. And then after release from prison, there's an incredibly high spike of increased risk of mortality. This is another thing I got from Twitter, because I think it really speaks to drug policy, that this is a structural problem, but we're putting the burden of making good choices on a person where they're just trying to survive this massive burden that we have created. And the Canadian Drug Policy Coalition says to end the racial harms endemic in policing in the society, we must abolish the war on drugs. So let's talk about decriminalization versus legalization. In the media, they're often mixed up. Decriminalization is quite simple. It's removal of criminal penalties for possession of drugs for personal use, and it decreases the scope of practice of police. Legalization is when drugs are available for purchase, and there's a wide variety of options for how this could look. Most people who use drugs don't have addiction, and most people who use drugs never come to the medical system. And the harms and benefits of drug use can be compounded, in some cases wholly created by drug policy. The unique pharmacology of any drug is only part of the story. And I definitely see that as a physician. Decriminalization is widely supported. Doctors of BC, the Canadian Association of Chiefs of Police, Mayors of BC, and CAMH in Toronto. And then it's a short read, but so poignant. Our wonderful Dr. Bonnie Henry here in BC published a white paper several years ago, Stopping the Harm, Decriminalization of People Who Use Drugs in BC. Portugal famously decriminalized drug possession in 2001, and that was for personal use. At the same time, they increased supports for social services, harm reduction, and drug treatment. Drug use declined. Drug use in youth declined. They had less people in prison, and they had no increase in drug-related crime. They had HIV seroconversions fall. More than 25 countries worldwide have eliminated criminal penalties for personal drug use to some degree. Most of it is about cannabis. There are limitations to decriminalization alone. You still don't have control over the supply of drugs and the harm from the supply chain. There's no tax revenue, and there's the ongoing involvement and profit for organized crime. So in Canada, it was so exciting. We have a legal regulated market for cannabis. What a wonderful roadmap to tell us where to go. So you can read the details online for how it's laid out for the federal law. What's interesting about Canada is the provinces and territories are responsible for determining how cannabis is distributed and sold within their jurisdictions. So it's a bit of a patchwork. We can't really do national research. Well, we will probably, but that it's different province to province for how cannabis is regulated. So each province has a flexibility to set additional restrictions, including placing limits on possession, personal cultivation, public use, and increasing the minimal age of use. So when we think about setting up a system of how people use drugs, what brings safety to that system? Like, what can we set up to make a system safe for the individual and for the public and be in that sweet spot at that bottom of the U-shaped curve for the public health model? So it's regulation. So that's licensing, standardization, inspections, supply chain standards, taxes, audits, thinking about who gets the profits, thinking about the limits on advertising, marketing, and packaging. So this is a big thing for tobacco, where it'll have the black and white warnings or the photos. That the tobacco industry is always trying to push back on that because it decreases their profits. But public health and our government are trying to create safety for our population by decreasing tobacco use. And so trying to have those warnings and standardizations. Price controls are important, driving restrictions, bylaws and zoning on where a product can be sold, standard hours of sale, bylaws on where use can occur, age restrictions, and limits on the amount that can be purchased on one time. So you always want to balance your regulation with suppressing an illegal market. So we want safety, but we want people to use our system that we create. And this can look like so many different things, like compassion clubs, like a government monopoly. We can have regulations for public disorder. Expunging criminal records is a very important part of the process. And it should always be paired with social programs, primary care, public health, social inclusion, and housing. So in Canada, I think we did a really good job of regulating cannabis. We tick all of the boxes of what to think about when thinking about regulating drugs, except for who gets the profits. Here are the technicalities of cannabis in Canada. So we have been criticized for the lack of expunging of criminal records. Like, really, no one should have cannabis possession on their criminal record. It's largely white people profiting from the industry. And then profits have gone to well-capitalized groups, usually with little connection to legacy producers. So people who are well-positioned, had funding, saw this opening market and invested are the ones who are getting the profits from our cannabis industry. There is ongoing use of the illegal market, but it is very deeply entrenched. So any shifts are positive. And there's no formal structure to provide benefits or funding to communities who are harmed by prohibition. Things are going quite well. Our data is still very preliminary, but we've not had the pediatric poisonings that we're seeing in some US states. We've not seen a change in cannabis use by youth. I read a paper recently that was criticizing our Canadian system because youth use didn't decrease. I was like, well, that's a lofty goal, but there was no change, which makes me happy. There were shifts in purchasing towards the legal market. So 68.4% of cannabis users reporting having obtained at least some of cannabis from a legal source, which is pretty impressive. So in young people, use didn't change, but when you take the whole population, use did go up. There might be a small signal that people who were older didn't report before, that they lied on the survey to say they didn't use, or that people who are older have increased their cannabis use since it became legal. So we can think about people in their, in the 60s, they loved smoking cannabis, but cannabis has changed and they didn't want to go to a drug dealer these days. But now that it's legal again, they're like, oh, I'm going to go try that thing that I enjoyed when I was young. This was a big moment for me. I don't know if you guys have ever had an embarrassing moment where you're talking to someone who is an expert in the field and you say something and you sort of think you're thoughtful and smart, and they sort of are like, oh gosh. But just wonderful Donald McPherson is so gracious and lovely. And I remember talking with him and I said I thought the legal age for cannabis use should be 25 because I was worried about brain development in youth and cannabis. And Donald said, it's not about who you want using or not using. It's who do you want to see criminalized? And that was a real penny drop moment for me, where I was like, oh, I can both want cannabis to be legal, and I can also hope that 14-year-olds don't smoke cannabis because of their brain development and psychosis and all of those complications that can come. But what are the things that we put in place to protect those youth? It should be like after school programming, safe housing, food security, swimming, sports, community, like there's so many things we can put in place that are protecting youth that are not criminalizing them. And so that was a real moment. I'll remember I was standing on Pender Street in the downtown east side, and Donald said that to me so sweetly. And I emailed him when I was preparing this presentation. I was like, Donald, can I quote you? And he was like, oh, absolutely, Christy. And he didn't even remember it at all. And I was quite embarrassed by it. So hopefully if embarrassing moments in your life, the other person doesn't remember. Cannabis in the downtown east side, it hasn't changed that much. Legal cannabis is more expensive. You have to buy at least a gram. You need ID. There's no retail stores in the downtown east side, and the retail environments are probably not very welcoming. They're very hipster looking in Vancouver. They're peak BC hipster. So I haven't seen my patient population move to the legal cannabis market. Here's another great quote from Robin Maynard. What would it look like to disinvest the incredible amount of public funds that are currently diverted towards police and prisons and invest instead in community-run, community-based institutions that serve people's very real need for security, education, and dignity? And then I always reflect about how does this interact with medicine, because I'm coming to this as a physician. And that I used to teach the medical model of addiction. It was in a lot of lectures that I did earlier in my career where we say it's relapsing remitting, that it's permanent and lifelong. And once you have the diagnosis of substance use disorder, you have it for life. But I mean, it never sat well with me. And now I don't really think that addiction is a medical issue. I think that medicine has pathologized drug use and medicalized well-being. And then I can even think back when I was in medical school, I memorized the DSM-4 for substance abuse. And one of the tick boxes was interactions with police. And so to think about how racist that is, that an interaction with police would give you a tick box on a psychiatric diagnosis. And that once you have that psychiatric diagnosis, you have it for life. Like it's very horrific. Like to think about how many ways racism is baked into this system. So here's just one little slide that sort of summarizes 10 years of really hard work that I'm quite passionate about creating safe supply programs for my patient population in the downtown east side at the Portland Hotel Society. So these are the medical options that I have right now. So methadone, Suboxone, Cadian. I have injectable IOT that's hydromorphone, and I've been just working really hard to try to get heroin as well. I have Dilaudid tablets. I have sufentanil, which is a fentanyl analog that is injectable and also can be taken sublingual. 7 times more potent than fentanyl. It's hard to do fentanyl in community because fentanyl that we give in the OR or in the ICU, the doses are much too low for the tolerance that my patient population has, and the volumes are much too high. So like if you were in ICU and you were not opiate tolerant, your fentanyl will be hung in like a mini bag by a nurse and like to drip into your IV to run over an hour. So it's not practical for doing a community. So we'll have to figure out different ways to deliver high dose fentanyl safely. We've also been running a fentanyl patch program for a few years. It's very successful. We've been prescribing Fentora, which is usually used for cancer pain or palliative care. It's a fentanyl tablet that dissolves in the cheek. I find it's been quite good for people who smoke, who haven't had success with the oral options. And then I'm soon to launch a fentanyl powder option where I have pre-loaded capsules of 100% pure fentanyl that will be mixed with a buffer. I am working with people who use drugs to figure out what that buffer will look like caffeine or dextrose. I hope to launch that next month. I have the fentanyl powder at the pharmacy, and then I'm working out the legal insurance things. And then all that to say, it is a joy to provide care for this patient population. And I love creating things that help the individuals, but that a program will never solve a problem that's been created by policy. So that, I feel for all these safe supply programs, we're sort of running uphill, and the hill we're running up has been created by our own government. And that it makes me so sad to think that Health Canada funds me to do these things, or the ministry, or this, I get lots of different funding. And I also, from fee-for-service family medicine, we're a social enterprise at the PHS. And we're working so hard, but we're working so hard because of a problem that the government has created. And so 4 things to sort of take away in summary: that we've had so much death, and it is so sad, and we all grieve. And that the world doesn't have to be set up this way, and that we can be angry about this. Our own government is spending money on policies that cause harm. And as a community, we can help shape a better future that is safer, just, and treats people with dignity. And that this is a process, that it's not going to be a one-time event, but that it's something we'll all keep working on. And that I think things have changed so much. When I started medicine in private practice in 2010, the only option was methadone. And then to think about all of the different drugs I have for my patients that I can offer in just 12 years is a huge change. Thank you.
Thanks, Christy. If people have questions, you can put them in the Q&A box. Christy, there is a question here from Mish in Toronto. Any advice on advocating for the expansion of our drug formulary in Ontario so we too can provide the other options like fentanyl for safer opioid supply?
Yeah, I mean, no, I don't have any advice. I always just start small and then have success. And then I find with the government, they want to announce successes. And so I try not to do media until I have a funder who I then can do media with. So even if you just start one person, that's how I started. It was in my first IO patient. It was just one patient. She lived at the Portland Hotel. I had a nurse there. He was passionate, and we were so worried about this person, and we wrote a protocol, and we did it just for her for a few months, actually. And it worked so well that we then looked for ways to expand it. So even if you just start one person, I think that makes a big difference. It makes a huge difference in that individual's life, and then it makes a big difference for policy and funding in the government.
And the Fentora and the fentanyl, the powdered fentanyl and such, that's covered under the BC drug benefits?
Some are and some aren't. Some of it I'm paying for with SUAP money, and then some of it is covered.
Great. Any other questions? Oh, there's a question in the chat. Please put your questions in the Q&A so I don't miss them. I've caught this one because we don't have any others in the Q&A right now. But we have another person asking, can you tell me more about the Fentora patch, and are you seeing that it is really effective? And what is the current development of the fentanyl patch?
So Fentora and fentanyl patches are different drugs. So they have different policies and different routes of administration. Fentora is a sublingual, so in the cheek, fentanyl tablet. And then it comes in 100s, 200s, 800s, and I think the 800s is the maximum dose. But we have no maximum dose in any of our programs because I'm not psychic. How do I know what dose someone needs, right? And so we created a titration protocol because you can't guess what someone's opiate tolerance is. And then it's so hard with how contaminated the street supply that people often will say, oh, I inject a point, but maybe it's only 40% fentanyl and 20% benzos and 30% baking powder. Who knows what's in that thing that they're injecting? So we do a titration. The titration with the Fentora program is quite fast because when something's sublingual, it gets into the brain very quickly. And so you can see within 4 minutes what the effect is going to be. The fentanyl patch is the sticky stickers that people put on the body, like looks just like the nicotine patch. It's much slower because it takes 12 hours to reach steady state. What happens with the fentanyl patch is a depot is formed in the subcutaneous tissue. So there's a sort of a steady state of fentanyl inside the body that's released into the blood. So it's the same level of fentanyl 24 hours a day. So people compare it to muscling, where you really don't have the peaks and valleys of euphoria and withdrawal. Some people like the peaks and valleys. And so that's why when I'm talking with them, I would pick a drug that has peaks and valleys for them to have euphoria and then not euphoria, hopefully never into withdrawal, but some people like the ups and downs. So for the fentanyl patch, it's like you're just at a steady state of fentanyl 24 hours a day. It can be limited by space on like skin on the body, that people are up to more than 1,000 micrograms, and that's per hour. That is over 24 hours released for them. And then what was the other question about the fentanyl patch? There's a second half.
Sorry, let me find it in the chat. What is the current development of the fentanyl patch? That question's not very
like how we develop the policy or how the patch is developed, I wonder. I'll say both. Our policies, we have a committee. So we have nurses, pharmacists, people with lived experience, physicians, and then I always get external people to review our policies. And that we always want to get as fast to as high of dose as we can. But we also, often it's a new drug, like for Fentora or these fentanyl capsules, like the fentanyl capsules especially, it's going to be 100% bioavailable. So I don't want to kill anyone on the journey, you know. So you witness people doing it at first, and you have a post-dose observation period to make sure you haven't sedated them too much. Yeah, so we work together. It's quite iterative. Like we'll often launch with just like 4 or 5 patients. We'll see how it goes. There's always patient feedback built in. So we'll do surveys or just meetings, or often it's just informal, like we're just meeting with patients doing their clinical medicine anyway, because we always provide full primary care with all of our interventions. And so you can just chat with people and see how it goes. And so as we go, we change. So for Fentora, we started our starting dose of 100 micrograms because that was in the product monograph. It's now up to 400. And then like the speed at which how we retitrate to people. So like say someone missed doses and they have to retitrate, it'll go faster. So we're always trying to get faster and bigger. And so that's how we develop our policies. For the fentanyl patch for development, I was hopeful that they could make bigger patches for us because it's so hard to take off 10 patches and put on 10 patches. We do Monday, Wednesday, Friday dosing so that someone can sort of have a bit of a schedule. Like if you're going to work or you're, you know, whatever it is that you're doing, if you come every 72 hours, which is the traditional fentanyl patch dose change schedule, it would be a different day of the week every week. So we just made it Monday, Wednesday, Friday. But the thing with the fentanyl patch is that I was like, okay, let's say I want a 500 microgram fentanyl patch. It actually would be the size of 5 patches. Like you wouldn't save any area. So I guess it would be safe that you could peel off just one patch and put on another. But I think it would also be quite uncomfortable to have a massive patch rather than multiple smaller ones. BC Pharmacare is looking into getting 150 microgram patches. So that might be nicer, like a few less patches for each person.
Thanks, Christy. I just want to, we're going to move on to Leslie and Wendy now. I did just, you know, just thinking about your U-shaped graph. And yes, we love the U's. And you know, you had down there about decriminalization, regulation, and prescription was in there. And just really want to emphasize that, yes, the safer supply programs are a way of decriminalizing. But there's such equity issues given that there's so few resources to support the programs that do exist. The capacity is just, everyone's completely working beyond capacity.
Yeah, and then it's so narrow to have every opioid come through medicine. Because I always think an opium den is like the nicest model of what could look like for opiate use. But for many of my patients probably wouldn't work because their tolerance is too high. But that you know, maybe there is a role for medicine in prescribing opioids for people who have opiate use disorder or people who use opioids, but that it should be done in parallel with a legal market. You know, I probably won't ever be unemployed, although I would love to be unemployed because I have no job anymore. Like that would be quite nice. But that if a legal regulated market is created from opiates, probably there'll be a parallel medical stream for people who need more support and are having a harder time. But I could see them working in harmony, that and that the scalability really is in that legal regulated market, not as much in the medical model.
And people have choices, right? About where and how to access care and what kind of scope that they want to get.
Yeah, and maybe they access both, like that they're in a medical program, but then they can buy extra on the side, like, or if they, plan to travel. There's so many complications for when you're in this medical model for your having to meet all of the regulatory requirements.
Yeah. Thanks, Christy. Who's going next? Wendy? Leslie?
Leslie can go next. I have Leslie. Is that okay, Leslie?
Yep.
Okay.
Fine. Well, I'm always impressed because I think Christy Sutherland knows everything. I really do. And then I think, what am I going to say? Thank you, Christy. I've seen your slides before, maybe not some of them. And I think like Rebecca said, I always learn something. I learn new perspectives, but I'm also greatly inspired by your work, because there is no reason on this earth why it cannot be expanded fully in this country and in other countries around the world. I mean, there is a reason, and that's drug policy. And anyway, thank you so much. Thanks for all of that, Christy. So the reason I'm here before you, I'm co-founder of an organization called Moms Stop the Harm, which was started by myself and 2 other women in around 2016. We don't even know exactly when it was, because we had all lost a son to drug harms. And we were all stunned, we were all angry, we were all in deep grief. My son died by an accidental overdose of pharmaceutical drugs after our family doctor had prescribed, way overprescribed oxycodone to him for a back injury over 7 months' time. And when my son went to our family doctor for help, because he was addicted, the doctor literally fired him as a patient because he was angry that my son had become addicted. So that was my first sort of foray into what stigma looks like. Anyway, and that scenario plays out every day in almost every ER, not Christy's clinic, but other clinics and medical settings. That stigma is there and is devastating to families and to the individual. And some of that devastation never leaves them. So as I said, 3 of us, Lorna and Petra and I, started Moms Stop the Harm after our sons died, pretty much in the same period of time, because we wanted to advocate for better drug policy. We didn't really know what we were doing. I mean, none of us had been in this situation before, but we were impassioned and enraged, and that gives you a lot of impetus. I have this one photograph. This friend gave each of us a metal, a quite beautiful wand, a magic wand, and each of these wands had a little crystal on top. And so each of us, and she took a picture of the 3 of us with our magic wands. And I think we really sort of felt that, oh, we can do this. We're magic. We're the moms who lost kids. There's nobody quite as powerful as moms who have lost kids and want to fight. So I always think of that photograph. I should put it up on the wall. So we started as an advocacy group, and we realized over the years that there were thousands and thousands of families who were in deep grief from losing a loved one, usually a child, from drug harms. And we were advocating at the same time, but we were also starting support groups. And ironically, the governments, both federal, for us with a SUAP grant, and provincial with we call the CHI grant, gave us money to expand our support groups. And we took it, and we have done that. And we have Healing Hearts for people who have lost someone, and Holding Hope for people who have a loved one struggling. you know, and the thing was what they said, essentially, actually, one of the ministers actually said that. She said, "You're doing our work, so we're going to give you this money." And I thought, well, okay, we'll do this work because we know it's necessary, but why aren't you fixing it so we don't have to do this work? Why aren't you fixing it so that our children aren't dying, so our families who are struggling with keeping their kids out of jail, keeping them alive, trying to find mental health supports for them and so on. Why aren't you doing that? So anyway, at this point in time, from the three of us, did I already say this? Our group has grown to 3,000 people across the country, all families who have endured these struggles and this grief. So we, even though it seems like most of our energy goes into the support groups, we are still, there's a pocket of us still advocating strongly and as loudly as we can for policy change. We rally, we stand on the steps of the legislature, we write letters, we actually get meetings with important people like the ministers of different Ministry of Mental Health and Addictions, both provincially and federally. You know, we're close. We always feel like we're so close, you know, that we can make them understand, make them do what we know is right, everything Christy said. But it doesn't work that way. I'm on committees that are so frustrating. The last one I was on, I think I'm still on it because I didn't really resign officially, but in the middle of this long meeting about recovery and treatment options for the future, I just kind of went on a rant about why are we talking about this? Why are we not talking about the ways we know, evidence-based ways we know to keep people alive, which is a safer supply? And there was kind of like a radio silence, you know. I was like, whoa, what have I done? But anyway, everybody just started talking about what they were talking about again. So, you know, that's how it feels to work on this, to try to get the politicians to understand. And I think these last numbers that came out here in BC that Christy mentioned, you know, 2,224 people died in 1 year in British Columbia, shook everybody to their core. I remember hearing the number, it was just last week or the week before, thinking, oh, that's a large number. And then it just sunk in. And I just thought, how can we continue to let the government not do what is right in the face of 2,224 people dead, which means that many families grieving, which means you can multiply that by 10 or 20, the number of people who are affected by each death. And that's a lot of people. This actually is I would say it's a rent in the fabric of our society to have this many people in deep grief, or this other group of people who are stressed beyond belief trying to keep their loved one alive. So really, you know, decriminalization and safer supply, you cannot separate them. Decriminalization in and of itself is not going to immediately stop the deaths. It won't. It's a society. It's a change that will take a long time to sink into the public, but it's something that is absolutely necessary for people who use drugs to move on to the next step, which is hopefully an issue of safe supply. And the frustrating thing is the governments on each level, and that's municipal and federal and provincial, have all know the right thing to do. It's like, it's not like they don't know. It's like what they do is they spend their time trying to figure out how to not do the right thing. Let's talk about you know, recovery beds. Let's talk about treatment. Let's talk about mental health supports that we'll put in place. It's all aspirational. It's all, not all, because there were 10 beds, you know, a few months ago that our minister said we've got more beds, and it turned out there was 10 more beds. Well, in a province where there's, I don't even know, 40 or 50,000 people who are taking on drugs from the illicit market and who may be addicted or may not be addicted, but could use treatment, 10 beds, I'm sorry, it's nothing. So I want to read just a little paragraph. We have, with Mom Stop the Harm, we have, I don't know, about 8 or 9 closed confidential Facebook pages where people can tell their stories. They can ask for information. They can ask for navigation. They can ask for a buddy if their child or their loved one has to go into the ER from an overdose or whatever. It's pretty rich and important to us. Anyway, this one woman who I don't know who she is, and I don't know what exactly her job is, but she said, "I am so tired. We lost another beautiful young soul this week. She left behind a tiny boy. I have worked with youth for 21 years now, and more young people have died in the last 2 years than in my entire career put together. The poison is out there, and I'm not sure we can do anything to change it. The stigma is so great. I am losing hope." And I read that, and I don't know, you can hear it in my voice. I was so affected by this person who's been in this for 21 years and who is losing hope. And I just had to get myself together, and she said that she doesn't think we can change it. Well, I personally am sure that we can. And if I wasn't sure that we can change it, if I wasn't sure that there was hope, I would stand up right now, turn off my camera and leave you, because why would I be here otherwise? I know we can change it. It takes everybody here in this audience. I can't see you, but I'm so glad you're here. It takes everyone to become a warrior, and whatever that means. And if that means talking to people in the grocery store lineup, or going to city council meetings, or writing letters to your politicians, all the things we know we can do safely in this country, which is always a little tricky right now, but talking to everyone that you can to change hearts and minds. This is the only way we are going to be able to, and with all the amazing advocates, change drug policy to get decriminalization, which we're working on here in BC. We've put in an application. It's flawed. It's going to take a while. We've got little pockets of safe supply. Thank you, Christy. And so we know it works. So we just have to keep working. So after I talk to you, I always say, as you walk out the door today, think of yourself, please think of yourself as a warrior, because that's what it's going to take for us all to fight for this. And I'm really grateful to be able to rant at you. And I hope that when you leave, you'll go chat with somebody and acknowledge people who are vulnerable. Thank you very much.
And thank you, Leslie.
You're welcome.
Oh, someone's just very quickly asking about whether this is going to be available to look at later. Yes, we're going to post the video. Christy, if you're able to share your slides or a PDF of your slides, we can put them on our website. Have you considered a national decriminalization platform? Would it be a more effective way than only advocating for one province? Mom Stop the Harm is national.
We are. And am I off mute? Yeah. We are national. And in fact, there are several of us, some who have been mentioned by Christy, that we are going into a roundtable with, I've met with Carolyn Bennett twice now, the Federal Minister of Mental Health and Addictions, and we have an invitation to meet with her again at a roundtable talking about both decriminalization and safe supply. So we are working as best we can on a federal level, and the bureaucrats in both levels of government know what's going on. I mean, everybody there almost knows the right thing. So I think it's a matter of helping the bureaucrats figure out how to do this and save face and do it right and all those things. It just takes a lot of reason and a lot of work. Donald McPherson, our hero, will be in that room with us, and yeah. So we're working on both, and municipal as well. So all levels.
We have a lot of questions that go back to some of Christy's presentation, but I'd like to hear from Wendy before we go back to those. Although Christy, I know your time is tight, but there's sort of more specific around safer supply, and I want to keep the conversation right now on decrim, and safer supply is a piece of that, but there's the bigger story as well. Also, Fola, can we do the poll now? We're going to do a really quick poll. If you could just like answer the questions for us really, really quickly. It just helps us with our stats and also helps us learn what our reach is like. Any other questions? Well, all right. Sorry, Wendy.
Oh, that's okay. No, it's sorry.
If you want to get started, you can.
I know we're over time, so if I know Christy's short on time, if
Oh no, Wendy, don't rush because of me. You take your
are
time.
you sure?
Oh
Because I
yeah,
know
no,
we're
till
all-
10:30. So
Okay.
you don't feel
Oh, I
rushed.
thought we were done at 10. Okay.
No, we got till 10:30.
Okay. I hate having to follow us and Christy because it's so brilliant. I saw someone in the chat mention that Christy, I used to be their doctor and how she saved their lives. And I can also say Christy was my doctor as well, back when the only option was methadone. So yeah, my name is Wendy Stevens. I'm your operations coordinator with Vancouver Coastal Health Overdose Emergency Response Team. I'm also a person with lived experience around substance use and HIV and sex trade work. A lot of my job is educating healthcare providers on things like stigma and trauma-informed care and harm reduction and you know, sort of substance use 101 and a lot of stuff that I just call how not to be a jerk 101. So I'm just going to talk a little bit about prohibition and stigma. And I also want to say I'm very much an ask me anything person, and the reasoning for that is really opening it up to be a safe space to ask questions. Is I think about my time when I was still out there as a person who used substances, and once in a while I would have these moments where I would think, if I can ever get out of here meaning, you know, my addiction and the street and so on, if I can never get out of here and help other people, then all of my time out there wouldn't have been for nothing. I had absolutely no idea what kind of context that would have been, but I'm super grateful to have worked as a peer support worker in HIV for 7 or 8 years before I came into this role. And now at Residency, we do a lot of educating with healthcare providers with lived experience as well as professional experience. So I'm going to talk a little bit about prohibition and stigma and how certain substances shape our views and shape our views of the people who use them and relationship with both of those people. So I'm just going to quickly give a couple of scenarios and just kind of think to yourself how these two things might hit your a little differently. So two people named Sarah and Joe. So
sorry, Wendy. Sorry to interrupt you. Some of us are having a hard time hearing you. It's cutting in and out a little bit. I'm not sure where you're located, like where you are physically. I'm wondering if it's possible to use the computer mic and sound. Just it might be a little easier, but that might be hard depending on where you're sitting.
Yeah, I'm in my office. So is this
maybe hold it a bit closer?
Is that better?
Yeah.
Does that sound better? Is that better?
I think so. Yeah.
Okay, good.
Lots of nods. Thank you, Wendy. We want to hear what you're saying.
Okay, good. This happens every once in a while, so I think it's just a universal say I tell you not. So I'm going to share just a couple of scenarios with you about a couple of people who I call Sarah and Joe. And Joe runs into Sarah one day. Sarah's very, very happy. Sarah, what's up? Why are you so happy? I passed my exam. I worked really hard. I passed my exam. Just all right. Let's go celebrate. I'll buy you a drink. So same scenario. Joe runs into Sarah. Sarah's very, very sad. Sarah, what's up? Why are you crying? And Sarah says, I failed my exam. I worked so hard. I can't believe I failed. So Joe says, okay, let's go. I'll show you. I'll buy you a drink. So think about those same scenarios. If Joe ran into Sarah And so I was very happy. And she passed her exam, and Joe said, all right, let's go celebrate. Let's go smoke some meth. In the same scenario, so I was very sad. What's wrong? I'll cheer you up, says Joe. Let's go shoot some coke. So you think about those substances, they're all substances. And, you know, there's whatever the harm is differently, but how differently we stigmatize one substance against, you know, another substance. It's super common, and, you know, it's just, society has just sort of created this narrative around certain substances being bad and something acceptable, which in my opinion is just really clear example of our rights being, you know, infringed upon. You know, up until October 17th of 2018, marijuana was illegal and it was criminalized, charged, but, you know, the government decided that it was actually not too bad for us. We get access to legally now. So Christy and Leslie talked a lot about legalization and decriminalization as well. So I'm just going to talk about a couple of the impacts of not legalizing substances. And obviously the first and most important is that people continue to die at an alarming rate. People have no choice but to go out to access their whatever substance they need from an illegal, toxic, unpredictable source every day. Every day in BC, 6 people are dying every single day here in BC from having to access that supply. And when you think about substance use and addiction, as a medical issue that it is, there's no other medical issue that we send people out to the street to access their medicine, to access treatment for their. You never really see someone, you know, scoring an inhaler for their asthma in a back alley, or scoring their, you know, their insulin for their diabetes, you know, in a back alley. It's substance use is one. So another one of the many impacts of not legalizing substances is a stigma that people who use substances continue to have access to healthcare. And I'm just going to quickly share one of my personal story from my lived experience around the stigma, some of the stigma I received accessing healthcare when I was still using substances. You know, I was very aware of how people saw me. I was, you know, still heavily into my drug use, working on the street in the downtown side, and I got an infection on my arm from injecting. And I've been to the hospital before. I knew how I was going to get treated. I didn't want to go. The infection just got worse and worse. It got sicker and sicker. I was accessing services I didn't say at the time, and they just kept saying, "Buddy, you've got to go to the hospital. You need IV antibiotics. You might lose your arm. You gotta go." So I kept making the excuse. As soon as I make enough money to buy enough dope to take with me, because I knew I wasn't going to be given much of anything for pain, and I knew I wasn't going to be given anything for withdrawal. So I needed to take enough with me. So of course, that never happened because I was confusing and not saving money. So some people put together some money, gave it to me and said, "Go buy whatever you need, go to the hospital, and we're putting you in a cabin so you know more expensive." So I did. Hated every second of it. So I got to the hospital, and sure enough, I was very aware of how people were looking at me. Because I was aware of that, I always tried to be, you know, a model patient and very courteous and very compliant. But I was in a bad place. You know, I probably had suffer days. I was sick from this infection and a lot of pain. So I remember they gave me a ridiculously small amount of morphine. And so the doctor came in and had a resident with him. And he was really rough. He was obviously not, well, he told me how he felt about me. I was crying, and he said, "You know, if you think this is unpleasant for you, how do you think you feel having to see people like you?" So I have no idea what I thought, but I remember I looked at the resident, and the look on his face was so shocked and so embarrassed for his colleague. So that just completely, you know, validated my fears and why I didn't want to access healthcare. So anyway, the doctor decided to drain the infection and came back, and it was really rough with my arm. And I was trying so hard to stay composed, but he told me that I was going to feel some pressure. So I turned my head, it was the corner of my eye, I saw him just grab my arm and stabbed it with his needle, and I cried out. And he leaned over to me and said, "If you don't shut up right now, I'm not giving you anything for him." And again, I looked at the resident and was with him, and his face was so shocked and so embarrassed. I have no idea if I shut up or not. Who knows? But when everything was said and done, the resident came back in the room, apologized for his colleague, and then asked me what could have been done, how could this have been handled better, make this better for me. And I have no idea what he said, but I like that story because it really shows two sides of one situation that was just so lousy and just so stigmatizing, but another side of a doctor who saw this happen and didn't want to ever be that doctor. An example for you, many years for someone to use a really lousy experience in healthcare. So yeah, that's really all I have to share. I just want to make sure to get back to answer all the questions. Yeah, thanks for letting me share. Thank you.
Wendy, thanks so much for sharing that. Some of that was really hard to hear. That's the kind of experience that you have had and that so many others are having out there. And I'm really grateful that you're doing the work that you're doing. We do have a question that I think would be great for you to answer. It came in a bit earlier. Let me just scroll up to this one. So the question is from, Allison. I understand you're focusing on a medical model, but can you briefly talk about what you've observed about the importance of other supports like trauma counseling in conjunction with medications? Can you address that?
Yeah, so I'm working on a project right now, about support for people who are using substances who experience trauma, which is pretty much everyone in the downtown east side. And part of it in the planning, we did an environmental scan, looking at trauma supports for people in the downtown east side of the room. Nothing free, that's for sure. There might be some stuff in there, but nothing free. So something that I know from my own personal experience is when I stopped, I've been on the street drugs for about 10 years. I have still on it for me as an methadone. I've been on since 2016. Something that I know, and I say this a lot, I've seen this a lot of clients, is when a big part of the addiction is, a small part of it is the actual drug, and a big part of it is all the other stuff that goes with it. For me, the needle, injecting, that was a big part of it. Making money, going to sport, all those things were a big part of it. And when I started on methadone, I got up to a therapeutic dose, and I actually had to stop, or I didn't have to keep moving all the time, because when I was using heroin, you're on the clock from the time you do your injections when you need to do another one, because you're gonna go to withdrawal, you're gonna get dope sick. And that was my driver for everything, was not going to withdrawal. So, and I've seen this in other people when you stop and you don't have to keep moving because you don't have to feed that opioid addiction. A lot of the stuff that you've been numbing or not dealing with catches up with you really fast. And that's why it's so hard. Like an example that I give is if a person breaks their leg, you can x-ray it and say, that's where your leg is broken. And this is what we need to do to heal it. And while it heals, there's going to be the symptom. So we're going to give you the symptom. But when a person is emotionally or mentally traumatized, they've got that trauma, it doesn't go away. You don't deal with it. It keeps us there. And it gets bigger and bigger. When a person is damaged emotionally or mentally, you can't x-ray them. You can't give them an ultrasound and say, oh, here's where you were damaged. Here's where you were hurt emotionally. We need to heal that. But when we feel that, it's going to hurt. So we're going to do something for the pain. That doesn't happen. So many people that I work with and that I educate, there's such a common perception that every person who uses substances, their end goal is abstinence, which isn't the case for so many people. To stop using, to have no substances is probably going to be more harmful than using.
It is a bit hard to hear you because of noise around you, but one thing that we've learned is that the video captures just what goes into your mic. So if anybody would like to rehear re-listen to what Wendy has spoken about today, check out the video. But we did capture quite a bit of what you also said, Wendy. So thank you very, very much. And all the importance of the wraparound care and all the different reasons why people use drugs and addressing all of that. Another question that came through is legalization seems like the best only non-medical way to ensure an uncontaminated drug supply, but it's such a capitalist solution. Is there another viable option that's not just profit driven? Anyone want to take that question?
Yeah, I can speak to that a bit because I think that it's going to take so long to unpack well, there's so many harms and so many levels, but to unpack the harms that the war on drugs has done to the drugs that we use, to think about how far cocaine is from a coca leaf. And that I think about like how people used drugs 150 years ago, that it was plants and that they were euphoric and that you could grow them organically and grow them yourself or for your family. But I think that, what I prioritize right now is getting fentanyl to my patients because I want them to not be dope sick and to have euphoria and to feel well. But then I think about like 10 years from now, maybe that same person will be, oh, Dr. Sutherland, I don't need to be on your fentanyl program anymore. I've joined the Opium Den Collective where we're growing our poppies together and then we all come together and smoke our opium together. Or we like to put our opium in our coffees in the morning and we all meet at the coffee shop. But I think that it will take time because we have to sort of start where the harm is now for tolerance and what drugs are on the market. And then I think as it gets unpacked, we can sort of move back to that plant-based natural drug use. And then that is much easier because I'm getting cocaine for one of my programs. And I ordered it from Mediska Pharmaceuticals, like that it's made in a factory. But to think about how far that is from the origins of like coca leaves and indigenous traditions and healing.
Thanks, Christy. I'll just do a little plug too. We're having a couple of people from DULF do a presentation with us in a couple of weeks on March the 15th, Alex. And we'll share information about that after. They're looking at these compassion club models or buyers club models. Obviously, it doesn't completely, it's not completely removed from the capitalist machine, but it is another kind of model and approach. So you might want to join us for that conversation to hear more about that.
And that in the cannabis regulation for Canada, you can grow your own cannabis plants, which I think is a wonderful, important part of that.
Mm-hmm. Let me look here. Oh, okay. A question here from Dylan. I'm not sure how to phrase this as a question, but I'm wondering about the distinction between safe supply, safe regulated street drugs, and withdrawal management meds. It seems that the government is usually talking about the latter, like withdrawal management meds, when they refer to safe supply, which makes it difficult to gauge the actual progress of safe supply implementation in BC. Thoughts?
I think that there's not much difference between those drugs. Like, I think it depends on what the person and what they want and what their symptoms are. Like if someone's having tons of sweats and I give them clonidine, it's not the same as in like 1998 when you were in the jail and you got clonidine for opiate withdrawal. So it's hard to tell by the medication. It's more by the context of the person's life and what their goals are. And that I will share sort of like a clinical pearl that I've thought of over the years that I remember when I first started IOT, some of my colleagues would ask me, how do you dose it so people are out of withdrawal but not euphoric? And I was like, what a strange question. Like, why are you trying to not have people have euphoria? And that that dose doesn't exist. And that I've also made most of my titrations. It's exceptional that it has to be a physician that lays eyes on you to have a titration in many of my programs, because why would I ever say no? Like, I don't know how you feel. So that's why we have no maximums, and that we have nursing-led titrations where the patient can just tell the nurse, I would like to go up, and the nurse follows the protocol, and then it's filled under my name. So it's much easier for titrations for people because there's no circumstance where I would say no. And that as well for restarts, I think about for that. I'm sort of going down a rabbit hole of how I've changed clinically over the years. So I'm away from the question, but that I used to have it that the patient had to see the doctor to restart a program, and I got rid of that. You don't have to see me to restart. Once you've been on it once, you can come back and restart. We had to put like limits for capacity, like for how long we would hold your spot. Usually it's 90 days. then you have to like re-enter the program. But if there's space, you can just re-enter. But otherwise, within those 90 days, because when I first started, I would get these phone calls from nurses on a Saturday because I was a doctor on call, and they'd be like, so-and-so's here, he wants to restart. I'd be like, okay, yes, thanks for calling. Like, and then I was like, why am I getting these phone calls? People should just be able to restart when they want, so that I have it. It's like a collaborative decision-making process with the patient and the nurse, and then verbal orders from me that get filled, so that there's not that like sort of one less layer of gatekeeping. So I guess, well, to come back to that original question of what the drugs are, that I think there's no way you can go by drug for if it's withdrawal management or if it's for recreation or for euphoria. Because like I will give people sufentanil in my clinic for wound care, and we'll get them out of withdrawal and get them a bit more comfortable to do a painful wound care process. And maybe they have some euphoria at the same time.
Thanks. Wiplub asks, as a physician in regular practice of non-safer supply program, do you have a suggestion on other care that should be packaged with safer supply? Primary care versus addiction medicine, screening for more comorbidities, sorry, I'm having trouble reading that. Monitoring, intensive case management, would still offer it without full wraparound primary care. Just looking for tips for someone not part of a full program who's working in isolation.
I think primary care, but that's my bias because I'm a family doctor, that I think primary care is the thing. And that primary care, I think, speaks to how drug use is not a medical issue. Like it shouldn't be a medical medicine's purview, but certainly primary care is. And so I was just actually having this conversation with a student yesterday, and she was talking about a case. She was like, what if I'm at my regular clinic and an 18-year-old comes in and they've started to use cocaine and their parents are worried and their parents want them to stop using cocaine? What do I tell them? How do I get them to stop using cocaine? And I was like, well, what you really should is get them to get an IUD. Like, maybe like make sure their contraception is okay. And like, talk with them about safety for driving and not getting in the car with an intoxicated driver, and maybe they want STI screening, or like, all of those beautiful primary care things that we can give to our patient population that improve their health. And that we're not in charge of who uses drugs or not. And really, we're delusionally grandiose if we think a nice chat with your family doctor is going to make you stop using cocaine. Like that, we need to stop embedding ourselves, like enmeshing ourselves in that. And that what the backbone of everything is I think primary care. Like primary care itself is a public health intervention that we decrease mortality in a population through like vaccinations, contraception, like well woman visits, chronic disease management, and that people who use drugs often are not welcome in those spaces and then die young of heart failure. And so, that's really where I see primary care role, is optimizing people's health.
Sort of along with that, Christy, sometimes I hear people talk about how if you're going to have the prescription, that like if you're going to be prescribing safer supply, it should be linked with wraparound care. So as a requirement. So if you as a client want to come and get safer supply from me, you also have to meet with a social worker. You have to go for primary care. What are your thoughts on that? The direct, like required.
I think it's very bizarre. I think coercing someone to do anything is always wrong. And it reminds me of back in the day where women would only get their birth control refill if they came in for their pap test. Like how paternalistic, how coercive to someone to say, oh, you need to let me put a speculum inside you in order to get your birth control pills. Like it's just so bizarre. And so I would never coerce or have requirements like that for people, but it's always just a welcoming and that option. So sometimes, I offer all my patients like, oh, a rectal exam, your colon cancer screening, and they'll tell me no way. And I say, oh, it's my job to offer and you decline. And I say, I'll just note on your chart, you don't want that. And so I think that it should never be coerced. Coerced primary care seems like it's very bizarre.
Sherry has a comment in the Q&A, because I think just to make sure we address this one. Is everyone aware of the current private members bill, Bill C-216, tabled by MP Gord Johns? This includes decriminalization of personal use, access to safe supply, increased harm reduction, treatment, and a national strategy. It passed its first reading and will be debated in the House of Commons in March and May. Thanks, Sherry. Any comments on that from the three of you? There's oh yes, Les.
Let's see, am I off mute? Yes. Actually, I wanted to comment before that, I want to, and yay for Gord Johns and yay for 216. And that's what we're going to go talk to them about. But anyway, what Christy was saying about primary care, and I told you that the short story of why my son died, or, you know, how he died, what his demise was. So I always like to say, what if Jordan went to this doctor, our primary care, our family physician, and said, I'm addicted, I need help, which he did. And the doctor said, okay, how can we do this? What looks good to you? What will take you from where you don't want to be to where you want to be? Do you want to start with detox? Do you have a counselor? Do you know what Suboxone is? If that had happened, chances are my son would be alive today. And that is like, so still 8 years later, you know, just blows my mind that this person who could have, and I've said to people since then, but I don't do it anymore, but for a while there I was saying, well, maybe start with your primary care doctor. I'd like to say that with confidence. I would like to say they will know what pathways to take, even if they don't know about addiction medicine, if they don't know about addiction, they don't know how it feels, they don't know how people present, and all the things that go along with it. Even if they don't know that they have the wherewithal to help this person. And like Christy always is saying, is like, it doesn't matter if the person needs a colonoscopy or the person needs whatever it is, offer it. If it had been offered, Jordan would have taken it. We ended up getting him into detox, but then when he got out of detox, we could find no support after that. It was like just big frickin' war. Yeah, and he ended up dying. And I think that if things had been better, he might still be with us. I just want to make that comment. Thank you.
Thank you, Leslie. It's amazing how important those connections, those relationships and experiences in care are, and making sure the doors are always open. I'm going to wrap us up now. First of all, big thanks to Wendy, Leslie, and Christy. I do also just want to make a quick note that we will be posting this on our website, and very quickly share some things about what's coming up next, also because I think it ties in with what we're talking about here. So our goal with the community of practice, let me make this all nice, is to try to help increase access to safer supply within Canada, within the medical model. And one of the things that we are working on is to create an advocacy kit for people who may not be able to access safer supply through a program, to be able to take to their primary care provider to help support a primary care provider to offer safer supply. And along with this, we also have a prescriber consultation line. So if you are a doctor, or if you have a doctor, or if you are a nurse practitioner or have a nurse practitioner and would like to learn about how to provide safer supply or want some support in providing safer supply, please join the community of practice, and we'll set you up with access to our prescriber consultation line, so you can check in with your community of other prescribers and get some help and support and advice and things like that, and share experiences. We have a couple of webinars coming up March 15th at 3 o'clock. We've got Dolph talking about a non-medical safe supply. And then on March 24th, the Safer Opioid Supply Guidance document, the daily dispensed tablet document that was created by a group of prescribers in Ontario. There's been an update to that they're going to be releasing, and they're going to come talk to us about the updates to that document, that guidance document. That's March 24th for our end of the month hot topic meeting. Yeah, if you have any questions, please visit our website. There's a contact us there, so you can just reach us directly. We also have a survey that we would love for you to fill out for us. That really helps us with planning. It helps us with reporting to our funders and things like that, and making sure that we're doing what you need for us to do. So thank you very much for joining us today, and we'll be posting this on the website within the next 24 hours, I would say, more or less. Yes, team? Nods happening. Okay, thank you all very, very much. Leslie, Wendy, big thanks. Gabrielle, thank you so much for all your mad typing while the presentations have been happening. It's such a valuable thing for us. Thank you.